Diabetes and TB has been quite a big deal here at this conference, and you've been to a session today. I think you were a little bit surprised by everything you heard.
Yeah, there were some interesting findings that were presented. I think one of the questions that we're all asking right now is how easy is it to put policy into practice? And of course, the rhetorical answer to that is that it's not always as easy as you might think. So a couple of the things that came out of the symposium this morning is that it does seem to be easier to screen for diabetics among the TB population as opposed to the opposite, screening for TB among diabetics. So Richard Brostrom presented some really interesting data from what they're doing in Hawaii, and we saw data from India and China as well, and it corroborates some other information that I've seen in Asia, which is that you can invest a lot of time and resources into screening for TB in a diabetes clinic, as an example, but you might not actually get that many TB patients identified.
And there was a paradox, wasn't there, about younger patients?
Yeah, so this was actually a surprise to me, but it was actually shown in both Richard's data and also the data from China, from Dr. Lin. And this is that among the diabetic population, it may actually be that the elderly are not those at greatest risk for TB. It may actually be a younger population, like in the age range of 40s and 50s, which was a surprise.
And are there difficulties of screening those patients?
I don't actually think that there would necessarily be difficulties in screening the patients, but I think just from an intuitive standpoint, conceptually, we would think that the elderly with diabetes would actually be at the greatest risk. But in fact, it looks like the data are actually pointing to a different age range.
A lot of the things we're hearing at the conference is how to get more effective treatment for drug-resistant TB, and short regimens are high on the agenda. What's been happening there?
Yeah, so this afternoon there was a really great symposium on short regimens for MDR-TB, and some very interesting presentations. Of course, the STREAM trial was presented, and they gave an update on the first stage, which is a 9-month or Bangladesh regimen, and the enrollment for that is almost complete. It actually has been progressing somewhat slowly. I think most people would agree to that. So we're all very excited that the first stage is almost complete now. Now there's the next stage, which will basically be adding bedaquiline, Janssen's drug. So it will be kind of a concurrent study of 2 new regimens, the 9-month regimen and bedaquiline.
Is there a feeling yet that short regimens have established themselves?
I guess the short answer to that is not quite yet. The 9-month regimen, of course, has been studied through an observational trial in Bangladesh, and that's actually where the first data were really produced. But there's no randomized controlled trial ever done actually for MDR-TB. So I think most of us are waiting on evidence. The great news is that there are currently 16 clinical trials right now that are in progress or in preparation for MDR-TB. The not so great news is that it will be 4 to 5 years before we actually have the data from those trials.
Right, now tell me about e-health and m-health that are featured here too.
Yeah, so I think we're all very excited about the potential of technology in helping to better develop strategies for TB and MDR-TB elimination. To me, I think the verdict is still out on this. I think there are a lot of creative ideas, and I think we should be thinking outside the box. But a lot of the ideas actually have not been taken to scale, certainly are not at the national level. So I think that's actually really the next step, is to scale up some of these great ideas, see whether or not they're sustainable, see whether or not they have any impact.
We heard rather disturbingly today from Médecins Sans Frontières that there's a deadly gap between the incidence of drug-resistant TB and effective treatment. I think only about 1/5 of patients who are known to have MDR-TB are actually getting the full treatment and getting it quickly enough. What did you make of all of that?
Yeah, I absolutely agree. I think we do need a global call to action. I think the global TB community needs to have these data at the forefront of their minds. There is absolutely both a diagnosis gap and a treatment gap. And the numbers don't even tell the full story, because there are many patients who are living with these diseases and dying with these diseases. So So I thought that it was actually very timely.
And there was an emphasis, wasn't there, on the fact that inpatient treatment might not be the way to go. It's costly, you have to wait, and it really doesn't solve the problem. So back to the community.
Absolutely, and the WHO has been encouraging what we call an ambulatory model for MDR-TB now for some time. So basically it means get the patients out of the hospital, minimize inpatient time, and maximize outpatient time. So in theory that should minimize infectivity within the hospital setting, but then it kind of raises new questions with respect to patient follow-up in the community. And so it kind of brings everything around to the importance and the priority of mobilizing the community to support these patients once they are outside of the hospital, in the community and in their homes.